Moving on to our next session on practical differences of diet in CAPD and versus APD by Dr. Sampath Kumar sir. I request the chairpersons, Dr. Nageshwar Reddy sir, Senior Consultant Nephrologist Yashoda Hospital, Somajiguda, Dr. Ravi Kumar sir, Senior Consultant Nephrologist, Gem Care Hospital, Dr. Gavita ma'am, Senior Consultant Nephrologist, Continental Hospital, Kajipavli, and Dr. Pradeep sir, Consultant Nephrologist, Lotus Super Speciality Hospital, Rajahmundry. I request the chairpersons to please introduce the speaker.
So good morning everybody. So it's welcome to the conference, Society of Renal Nutrition Conference. So it's my privilege to welcome and introduce our speaker today, Dr. Sampath sir. So he practices nephrology for the last 30-35 years at Madurai Meenakshi Mission Hospital, trained many DNB students and who are good nephrologists in their own cities throughout India, especially in the southern part of the India. So he has more than 100 publications, book chapters, especially peritoneal dialysis. So he used to do the peritoneal dialysis himself, both bedside and in the OT, peritoneoscopic method and ultrasound guided. So he used to teach many students during the DNB period. So it's my privilege to introduce him, and I request him to start the talk, please.
Thank you. So, good morning to all of you, and I would thank Dr. Swarnalata for relocating my topic because I was supposed to talk yesterday. So, this is when I received this topic, the practical differences in of dietary advice in CAPD versus APD, I thought myself, oh God, I don't think I have addressed any of these when I spoke to my patients. Then I dug into the literature and found that there are subtle differences. And so, what is happening in peritoneal dialysis, as it happens in hemodialysis, is that we are overly focusing on the urea and creatinine levels. In our patients also pour over the reports, but leaving the life-saving nutritional optimization dangerously neglected. And we found that only around 10% of the total dialysis population, less than 10% of the total dialysis population in India are being dialyzed with peritoneal dialysis. And I happen to be the captain of the sinking ship of the Titanic. I happen to be the president of the Peritoneal Dialysis Society of India. And so it is up to the younger generation who are in this audience to see to it that the ship doesn't sink. And we found that the silent threat of the malnutrition is there. A staggering 60% of the protein energy wasting is prevalent in peritoneal dialysis patients. And this is one of the landmark work done by my friend Dr. Prasad. Narayan Prasad is here. So he did this out of 283 patients. He saw how much malnutrition was existing, and we found that when you apply the subjective global assessment, the malnutrition was prevalent to a tune of close to 70%, 70 to 75%. So if you found 3 PD patients, 2 of them will be having protein energy wasting or malnutrition. So very, very high prevalence of this. And the factors are multiple. You found that starting from the socio-economic factors to limited use of nutritional assessment tools. So only when you know what is happening, you will be unaware. So ignorance is bliss. So you will find that many of the patients that you are treating are already malnourished. And the multiple validated assessment tools are there for malnutrition assessment, But unfortunately for a nephrologist who is sitting in the busy clinic with a very long queue which has to be seen, you found that it is impossible to assess the nutritional aspect of every patient. So, we need to have at least these have to be inculcated into our daily practice. At least 3 to 6 months you should have some nutritional assessment of your patients who come to you on the OPD basis in peritoneal dialysis. So, what we find very useful is this Randerson method of assessment of the protein nitrogen appearance, which reflects the urea nitrogen excretion, which is dialysate plus urine, and also the non-urea nitrogen losses. Very simple clinical formula which you can use, and you can also ask your sisters to do it. And so, what you do is you ask them to bring the bags that they have used the previous day, and also have a urinary urea assessment, and you make these calculations. So, the core concept is that the protein intake is you can assess by the nitrogen appearance and multiply it by a factor of 6.25. Why this factor of 6.25? Is that the nitrogen content of the protein molecule is close to around 15%. So, if you multiply by a factor of 6, you will get the protein intake. So, a very ultra quick clinical rule is that we do not look at the blood urea nitrogen assessment in our lab. We only get the urea results, and urea, as you know, is the nitrogen content is close to 50%. So, when you find that the total urea which we are able to measure in a patient on a per day basis, if it is so many grams per day, and you multiply by a factor of 3, you get the protein intake. So, this is a very quick clinical guide. When in a busy clinic, you assess how much the urea level which has come out in the peritoneal dialysis bag and also in the urine, grams per day, multiply by a factor of 3, you get the protein intake. This is, mind you, this is very important that this fellow should be having should not have hypercatabolic state. See, normal target in a PD patient, you should achieve a protein intake of more than 1.2, close to 1.3 grams per kilogram per day, which is a very tall order. You will find that even if you give them good nutritional support, you will rarely reach a factor above 1.1 or 1 or 1.1. So, when combined with the serum albumin and also body composition indices and a dietary recall, you will find a good rounding up of the practical tool for the nutritional assessment in PD patients. So, the dietary advice for a PD patient is that the energy should be so much, the sodium intake should be less than 2.3 grams per day, the potassium ideally should be liberal intake of potassium is indicated, and phosphorus and calcium and vitamins. So, this is in contrast to the hemodialysis, where very rigid restrictions are important. So, what is good for hemodialysis may not be correct for peritoneal dialysis. Without a dedicated counseling, patients naturally default to the severe restrictions in hemodialysis. So, dangerous over restriction is bad, and dangerous over restriction, especially in potassium, is not leading them anywhere, because hypokalemia is now found to be a very important marker of peritonitis in PD. So, you need to do some unlearning from hemodialysis for PD patients. So, very strict restriction in sodium in fluid in hemo, but slightly more liberalized in contrast to hemodialysis. potassium, as I already told you. Protein, you need to increase the protein intake. Carbohydrate, you need to cut down. So, we shall see why. One of the important aspects of the dietary counseling when it comes to a patient on CAPD versus automated PD is on the sodium. You find that automated PD, there are multiple short exchanges are happening, especially at night time, and this sees to it that the sodium removal is compromised. So, this is something called a sodium sieving effect. More water comes out in the dialysate than the sodium, and so sodium removal is not all that great when somebody is on APD, whereas in CAPD, because of the long exchanges, you have a better sodium removal in the dialysate. So, this was a study which I could get my hands on, where they did the comparative analysis of the sodium removal treated by CAPD versus APD, and you found that the CAPD, where the clear bar, you found that the CAPD had a higher sodium removal than APD, the bar with the dots. So, the important takeaway is that CAPD removed most sodium, more than 80 milliequivalents, whereas less than half of it is removed by APD. So, the clinical pearl is that you need to be more aggressive about sodium restriction in APD patients, because they are more prone for hypertension. What about potassium? Again, bedside clinical rule is that for every 10 milliequivalents of removal of potassium, there will be a 0.1 milliequivalents per liter reduction of serum sodium levels in PD patients. For CAPD removal, potassium removal is greater in CAPD, close to 30 to 40 milliequivalents per day can be removed, telling us that you can be liberal with the potassium intake in CAPD patients. APD removal is slightly less, approximately 10 to 20 milliequivalents per day. So, less risk of hypokalemia with APD. And the potassium paradox, I am sure all of you know about it. The animal processed food have higher availability of potassium because of the animal sources and the inorganic food additives which are there, whereas whole plant sources, the intact plant cell walls require mechanical and enzymatic degradation. So, when you are promoting the plant-based diet which promotes alkalemia and also better insulin secretion, driving potassium into the cells, this with a high dietary fiber intake, it beautifully reduces the problem of hyperkalemia in your patients. Especially in PD patients, you need to have higher potassium intake. And the second aspect is about the protein mandate. You find that close to 10 to 15 grams of protein is being lost in the peritoneal dialysis exchanges per day, which is very huge. So, you have patients quickly going into protein energy wasting when they are on peritoneal dialysis, and so your the protein intake targets should be much more than in hemodialysis even. But the dilemma is that high protein intake means high phosphorus intake too, because always protein is coupled with the phosphorus. But the issue about phosphorus coming from the dietary aspect, especially plant-based diet, is that the phosphorus is bound to phytates. These phytates do not release phosphate as easily as in the animal food, so that less than 50% of the phosphate is released. So, the bioavailability of phosphate is much less with the plant-based diets. So, that is why we say that plant-based protein is much better for your PD patients as for hemodialysis patients. So, Indian patients can safely consume large quantities of protein-rich dals and legumes to meet their dietary this thing. So, the other aspect is that dialysate delivers a hidden 300 to 500 calories of internal meal. So, the invisible sugar which is always there in your PD bags has to be taken into consideration, especially with the caloric intake. So, APD patients require a higher basal insulin doses at night to counter the continuous nocturnal glucose surge which happens in the cyclers. So, especially important is that the nighttime dose of insulin should be there in your APD patients, especially diabetic patients. So, when you take up the icodextrine, you found that for long dwells significantly reduces the glucose absorption and improves the ultrafiltration capacity also. So, the important thing is that you need to be careful about the glucometers when the older glucometers, the PQQ meters which are no longer available, but you need to be aware of this, that it can show up the sugar levels to be very high. So, this is the plant based diets, and you saw that often the unprocessed fruits, vegetables and whole grains and legumes are the way to go when you are having dietary counseling for your patients. The systemic benefits are multiple: reduced trajectory of mortality, and the dialysate flow picks up because of mitigation of constipation. You also saw that the dysbiosis is less. So, the important thing is that increased fiber intake has been shown to have a better flow of dialysate fluid. So, anybody with a fiber intake of more than 12 grams per day, it correlates with a lesser inflammatory markers, and so fiber intake has to be aggressively promoted. And you also know that dysbiosis happens in the gut in uremic milieu, and when you take plant based diets, this dysbiosis because of the increased short chain fatty acids generation reduces the dysbiosis. So, multiple advantages are there when you use plant based diets. Lesser availability of the TMAO, which is a very important metabolite, very heavily implicated in atherosclerosis, coming from the meat based diets. You saw that the volume and sodium intake are less, and you are able to correct the acidosis better. The concern about lower albumin levels, because you are going to give lesser proteins coming from the plant based diet, is also unfounded by this study, which have shown that albumin levels are actually better in plant based diets, because the liver's synthetic capacity for albumin improves when there is less inflammation. So, multiple supplementation needs to be done when you are putting somebody on dietary high plant based diets. Vitamin B12, vitamin D, selenium and iodine should be monitored, and also fluid management. So, reframing the PD nutrition is that the potassium can be taken up in a big way with plant based diets. Phosphorus is bound to indigestible phytates, and the protein quality is not less with the plant based diets. So, when I was given this topic, I did a reality check of my patients, a group of my patients who are coming to me on the OPD in the last 1 month, and the reality truth is that it hurts. So, out of 15 patients that took up this study of the dialysis, protein adequacy, I found that only 3 of them passed this test and 12 of them were severely malnourished. So, I have multiple works to do. The clinical counseling rule is that when the plate is filled with food items, tell your patients to go for the protein items first and then take up the carbohydrates next. So, the first prioritize protein intake before carbohydrates, and translate the grams into visual Katori portions. Don't tell them about grams, tell them about the cups. The third is that clear bowel ensures a clear bag. Go for a high fiber diet and combat APD thirst with a microhydration. Go for small sips of fluid, don't go for a tumbler full of water. So the conclusion is that the differences are very subtle, the dietary differences are subtle in APD versus CAPD. Sodium, stricture restriction, potassium, liberalize the intake, glucose B, very strict in CAPD, protein, increase the intake in CAPD, phosphate, go for individualized phosphate assessment. Thank you very much for the excellent hospitality. Thank you.
Thank you, sir, for your illustrious presentation and clearly telling us the difference between APD and CAPD. A couple of things I would like to ask is that is there any difference in the protein losses between the CAPD and APD? And if so, does it depend on the membrane status as well? I mean, removal of the sodium, potassium, and protein? Because generally, in the practice, the people with high transport status, we move to APD. Yeah. So is there any difference in the...
Yeah, see, I could not get my hands on this specific aspect of the protein losses in APD versus CAPD, but when you look at the logic, you find that the CAPD losses of protein is going to be more, because in APD you are going to have rapid exchanges, not much time is given for the protein losses to occur. So definitely CAPD losses are going to be more.
Thank you.
Sir, in your study, last 1 month, 15 patients, was there any difference between CAPD versus APD, sir, or all those are on CAPD?
Almost all of them are on CAPD.
Yeah. So one small doubt, like CAPD patients, they usually tend to have decreased food intake or because of abdominal bloating or something. APD patients at least do better. So do you think that if someone is having on CAPD severe malnutrition or they're going into malnutrition, it's always better to convert them to APD, or what do you say?
I don't think this is going to help. So this is going to be choosing between the devil and the deep sea is not going to be useful. I think you need to address the malnutrition in either in CAPD or in APD and give better nutritional counseling and then reduce their inflammatory status, and then don't change the modality.
Thank you, sir.
Yes. Yeah. It has been shown by multiple studies that amino acid based peritoneal dialysis therapy is definitely better in the long run for reduction of the protein energy wasting. But unfortunately, we have not had any personal experience of this amino acid based peritoneal dialysis fluid. Maybe Professor Jaji will be able to tell us about his experience in using it when he was in Canada.
So, sorry to interrupt. I must say, we use Neutralin in the UK. So, it has a benefit, but I think to a limited extent. And that too only for severely malnourished patients.
Yeah, basically when we started using amino acid infusion on a experimental study in Toronto Western Hospital, 1% amino acid. The disadvantages were, although there was a rise in the overall nutrition, the disadvantages were, one is metabolic acidosis. And over a period of time, a number of patients did not have the benefit as we expected. So this is something you have to be kept in mind when you use amino acid containing 1% amino acid containing dialysis fluid.